Welcome to the Connecting Health Professionals with People podcast, brought to you by ProNex Inc. I'm Eran Kabakov, and with me today is Dr. David Mahony, who is a clinical psychologist and a technologist. He's also the creator of the MPABS psychological assessment for bariatric surgery candidates. Welcome, Dr. Mahony.
Thank you.
Every time I meet a fellow clinician who has delved into technology, I'm really curious to hear the story on why and how. So how did you first get into bariatrics, and second, what drove you to the technology side of things as well?
Well, thanks for having me on the podcast. It's a big question. So I am a clinical psychologist, and way back in 2001, a bariatric surgeon called me and asked me if I could do psychological evaluations for their patients. Every bariatric patient needs psychological clearance before they're approved for surgery. And I quickly learned that we didn't know much of anything about, as psychologists, we didn't know much about weight loss surgery or obesity in general. Very little was known. The other part to it was that there were no formal assessment systems for bariatrics or obesity or weight loss or anything like that. If you look at any other diagnosis like ADHD or depression, there's dozens of formal tests that you can give to patients to assess them. But there was nothing for this field. So over time, as I learned more and more about bariatrics and what patients go through and what problems they may experience, I developed a psychological test specifically for that population. And essentially, it's a questionnaire where we ask about 115 questions. And in this way, we can get a lot of information from the patient before you even meet them, and we can compare their answers to the answers of other patients. So we can see things like if they score really high on depression or really low. And we try to measure all of the things we think are relevant to bariatric surgery. And in this way, we can make the evaluation a lot more standardized, and it can be done a lot faster. So originally, I would do interviews, and you have to go over so many things: their mental health history, their diet history, their social history, their education. It could take hours. But now when we administer the test, we get a lot of information, and then we can see what areas you really need to get into depth on and which areas you don't necessarily have to pursue further. And originally, like most psychological tests, it was administered paper and pencil. So the patient will come to your office, you give it to them in the waiting room, they fill it out, then I would score it. I originally scored it on an Excel spreadsheet, and then eventually, with a lot of trouble, no one ever tells you how much trouble it is to create this technology. with a lot of trouble, we created a website where you could score it. You can go online and kind of score it. So now clinicians all over the world could actually use the test. They would administer it paper and pencil and then go on the website and score it. And that was good because I started to get data from all over the country and all over the world. A lot of English-speaking countries, South Africa, Australia, started to use the test. And we started to learn the differences with these countries. So that went along for years, and essentially I would see maybe 2 or 3 patients a week. You were limited by how many patients were referred to you, and could they actually get to your office? But over the years, I really got into it because very little was known. I published a lot of research. I'd go to the conferences and present, things like that. And it sort of became a niche specialty. And then COVID came and the rules changed. And now, instead of having to come to our office, all of outpatient mental health went telehealth. So everything is like this with a Zoom call. So now, instead of being limited to the patients that could just physically get to your office, you were only limited by where you had a license. So I started getting phone calls from surgical programs all over New York State. That's where I had a license, who knew of me. And so now I was seeing patients all over the state. I then got some licenses in other states. And things really exploded. And now I have 7 clinicians working all over the country, doing these evaluations. So it's become sort of like a telehealth startup company.
Yeah.
And we have technology is still the hope and the dream, and I still want to pursue further because I think there are a lot of technology solutions in this field. It's a very sleepy field that really hasn't kind of embraced technology, and there's a lot of things that can be done. So now we're at the stage where we can actually administer the test remotely, and it comes back to us already scored. So if you're a patient, you call up, you give us your email, we send you just like any kind of any kind of medical thing that
That asks for your information.
you get an app and you have to kind of fill out all the forms and everything like that. But we can also administer the MPABs and other psychological evaluations, and then the provider gets it already scored. So before you see the patient, you already have the test results, and it makes it a lot faster. And you can do most evals within an hour.
Nice.
And have a pretty good sense of who the patients are. It's incredibly easy for the patients because they can do it from home, from their office, or a lot of them just do it from their car.
Mm-hmm. Yeah.
Which is fine. So, and I think so technologically, with the advent of telehealth, things have really changed in this industry, and I think there's a lot more to go, a lot more that can be done with the technology.
That was something I was curious also about because I was reading on your website, right, which is mpabs.net. I was looking at the history of the tool, and one of the things you mentioned that back in 2000 when you delved into it, you were looking at NIH data and they didn't have anything. There was nothing to build on. Do you feel that the field has gotten better overall? I'm not talking about necessarily specifically the bariatric surgery community, because I'm sure that there's been some progress there, but outside of the bariatric surgery or bariatric care, we'll say, do you feel that there's more data and we're better suited to treat the specific population?
In terms of the psychological issues, I think there's a lot more data. There's a much better understanding. We specifically look at kind of what kind of problems, psychological problems, might occur after the surgery, and we want to identify them and step in and treat them. So we've gotten a lot better at understanding what problems actually happen and how to identify them. Stepping in and treating them is a lot more difficult because most patients don't want to do that. So, we may identify somebody who's at high risk for post-surgical alcohol use problems, and we offer to work with them, and they often just sort of drop out.
And disappear. Yeah, well, the individual choice is still their choice, right? I think having the understanding and the ability to bring it up to the surface and say, look, let's tackle this. I think that's huge. That's huge.
The other thing we've gotten much better at, we're supposed to look for patients that may have problems, right? But in some of my early research, I realized that about 30% of the patients that are going through the psychological evaluation and being cleared, so they have medical insurance, they meet all the requirements, they receive all the clearance, about 30% of them don't pursue the surgery, which I was shocked by because they would really benefit. And so now we're able to identify them. And generally, they don't do it because they're scared of surgery, or they think they can lose the weight on their own with diet and exercise. And I generally believe that those aren't good reasons not to do the procedure. So now we can step in and also work with them so that more patients that will benefit from bariatric surgery will actually, go through with it.
We're in the process of we're in the process of onboarding a patient for surgery. Do you come in? Like obviously they have the first call with the office. The office does some sort of pre-qualification and they get them on the information seminar in the process. But where between that information seminar and surgery do you come into play?
We can come in at any point. So traditionally, a patient would go in to see the surgeon. They'd receive like a packet with a list of all the clearances they need and all the doctors that they can see. And then it's the patient themselves would call, make appointments, and do that. Depending on their insurance, it may take 3 or 6 months for them to be eligible. Sometimes they call us first and we see them right away. A lot of times they wait to the absolute last minute and call us. So we can be involved at any point in that process.
And I'm wondering if those 30% that decide not to have surgery, would better education from the practice side might help those individuals that really should benefit from surgery go through with the decision, or is that more because that's just human nature and they're like, no, I'm gonna give it one more chance because I think I can do it?
I think they can benefit from more education, more information, and just a better understanding. For example, a lot of patients are scared of surgery. But one way to look at it is it's actually more dangerous to not have surgery. Being obese, they say, is equivalent to smoking a pack of cigarettes a day. So not doing it, you're eventually going to have problems. Whereas if you have the surgery, it's a very, very low likelihood that you're going to have any complications. Similarly, with patients that say, hey, I'm going to try diet and exercise again, usually they've tried that over and over and over. And what we usually see is they say, yeah, I'm going to try diet and exercise again. And then they come back a year later and restart the whole process and go through everything. So we try to educate them on the fact that, once you reach a certain BMI, diet and exercise is just extremely difficult. And most patients don't succeed. It's really hard. It's just too hard.
Yeah.
So yeah, I think there's a lot of potential for bariatric programs and psychologists and all the providers to sort of educate and encourage and give patients a better understanding so that they do go through with it. Less than 1% of the eligible patients in the country actually have the procedure. And when you see the results, it's a wonderful procedure. In the 23 years I've been doing this, I've never seen a patient come back and say they regretted doing it. They're always happy. The results are always good. So it's really, and I think it's a big psychological barrier that a lot of these patients don't even reach out to the bariatric surgeons to even start the process.
Well, I think there's probably there are probably many reasons why they don't reach out. I think that the stigmas and the prejudice that they feel and encounter is part of it, right? And if you're going for surgery, you kind of gave up on doing it yourself. You're maybe not strong enough, which is ridiculous. It's not. It's completely not true. And me being a physical therapist, I tell that to my patients that come in with a knee that needs to be replaced or a hip, and the mentality is, no, I'm gonna bear through it, and I'm gonna make it better somehow. I'm like,
Yeah.
it's a losing battle. You're better off having the surgery and having quality of life that you could dream of. But getting over that hump of, oh, it's the surgery. I can understand. I can understand.
Yeah.
So I understand that you're doing it, and you have a team that is performing the evaluations for practices. But if I was a psychologist out there and I want to utilize the tool, I can go online, go to the website, and sign up to use it as well.
Correct. Yes.
And basically, I will have an account where I can send the invite to the patient I'm evaluating. They'll fill it out just like you doing it, and then I get the results and I interview them and write the report.
That we haven't mastered yet. There's a lot of technical hurdles. So we can do it through our electronic medical record program, but not everyone can.
I see. So they would use the service as a scoring mechanism.
They can use the scoring mechanism, or some of them will use electronic medical record systems that will allow them to administer it and get the results. Yeah, my hope is that, right, everyone will have access to a system where they sign up and they just send a link to the patient and then they get the results. Although, as easy as that sounds, it's very, very tricky. It ends up being, I guess the thing is, it ends up being expensive and very time consuming to build these systems. And so I'm in the process now of experimenting with different systems. So hopefully we will have something available.
Yeah, I always found technology being more expensive on the end process where you have to maintain it, because by the time you get it out there, the internet has changed, and now you need to update this and that, and also I think with healthcare in general, I remember putting together the first product myself for my own purposes. And that was before HIPAA was a thing, right? And then suddenly we have this product and HIPAA comes along and like, wait, I can't do this and I can't do that. And so anytime communication is involved in healthcare, it makes the process more difficult and more expensive, unfortunately. I also think that as healthcare providers, we are slow to adapt to new technology. So that's on us. If I can speak for me and my colleagues as a group, some may not agree. So unrelated to the subject, I'm curious to learn about a personal professional habit that you find is helpful to you, that perhaps somebody who views this at one point will say, you know what, I'll take it. Let me try that. What's just a thing that works for you in your professional life to be successful?
So one of the things that I struggle with and my team struggles with is when to not clear a patient. Like, when is a patient not suitable for surgery? And so for most patients, the evaluations is pretty matter of fact. You know, they're perfectly good candidates. Then you get about 5% where it's pretty clear they're not good candidates. There's active substance or alcohol use, suicidality, things like that. But then there's about 5% who come up with something you've never heard of before, a situation you've never heard of before, or it could go either way. And so one of the habits that I developed is to say, let the decision make itself. And what I mean by that is I will try not to make the decision, but then write the report, go through all the data, write the report, and usually by the end it's like, okay, I know if I should clear them or not clear them. I kind of know. And a lot of times, clinically, and this is probably true in any area, any field, you're not really sure what to do. And so we actually have to still write a report out. And so going through that process sort of makes the decision, it helps us make the decision. Also, what I'm doing now is we are having a grand rounds where every other week we'll get together and discuss cases, which as clinicians, people usually don't do, so we'll have sort of formal discussions, and I found that to be just wonderful. I've been doing this over 20 years, and sometimes one of my colleagues will point something out that's really obvious that I just, completely didn't see. So I think having these mechanisms to help you sift through and make decisions on the difficult cases has been extremely helpful for me.
Thank you for that. So if I'm a clinician, I'm a psychologist, and I want to reach out, I want to try the tool, where should I go? What should I do?
You would go to bariatric-codex.com. You would request an account, and then we would get in touch with you.
Sounds great. And more information is on the MPABS website as well, the mpabs.net.
Right, mpabs.net. I have a lot of information, just basically explaining what the test is, what it does, things like that. You want to be careful because you don't want to give out too much in case the patients find out. They can go there.
Understood. Well, Dr. Mahony, thank you so much for taking the time to meet with me today. It was really interesting. I'm Eran Kabakov with the Connecting Health Professionals and People. To learn more, let me do that again. I'm Eran Kabakov with Connecting Health Professionals with People. To learn more about the podcast and sign up to be a guest, please visit pronexinc.com.